Hello, everyone, and welcome to this second phase of the fifth stroke study day of the stroke department of the Northern Care Alliance, also Salford Royal. Hopefully, we of course won't have interruptions. YouTube would need to crash in order for you to be prevented from watching this presentation. What I'm going to talk about is about the use of antiplatelets early in the secondary prevention of acute non-cardioembolic stroke and TIAs, which sounds a bit like a mouthful, but it's a very restricted scenario, which hopefully I'll be able to convey the importance of. So stroke is certainly a highly prevalent condition in our world. This is data extracted from the Global Burden of Disease, a series of studies which have been going on since the 90s under the auspices and funding from the Bill and Melinda Gates Foundation. As doctors, you are very fortunate, and we are all very fortunate to have these data and this information, because it's kind of the first world census on diseases, and I think it has helped enormously in reshaping the panorama of education, that instead of focusing on very rare disease, which of course are important to those who suffer from them, education is able to focus on how to treat well the most prevalent conditions so as to reduce their burden. And burden is exactly what we are concerned about. And we can see one extract from that information published in 2020 from the population in 2019, and we can see that it hasn't changed between 1990 and 2019. That ischemic heart disease is the first cause of burden to population between 50 and 74 years of age, but a stroke still occupies the second place in terms of disease burden as well. In around the world, a stroke would account for 9.3% of disease burden amongst all other conditions. You can see most of them are blue, and blue conditions here are non-communicable diseases, which are mostly preventable. So also the big message is about primary and secondary prevention of all these conditions that, although it's not the focus of this presentation, focuses actually mostly on highly preventable conditions that, after a few changes to lifestyle, would drop enormously. This table is key in understanding why we are such a pain, and why we make such a fuss in acute stroke care about the early start of antiplatelets, and about which one to use and which one to give in which particular circumstances. It's because about some 25 to 30% of strokes are recurrent strokes, and those strokes are part of the burden of global burden of a stroke. So, but this table shows us that most stroke recurrences happen early, and you can see that 6 hours after the onset of a stroke, the risk of a new stroke is about 1%. That is, 1 in 100 people who have a stroke will have another one in the first 6 hours. That doubles at 12 hours, and that triples by 2 days and by 1 week it will be 5%. So 5 in every 100 patients will have had a new stroke if no therapies started. And by 2 weeks it will be 10 out of every 100 patients who have had a stroke having a recurrent stroke. So this increase is very steep in those first 2 weeks, and then tends to plateau by 1 year. You see that it will be much flatter that curve afterwards, and by 5 years, approximately a quarter of patients with a stroke would have had another one. So understanding this table is at the core of what we are going to talk about, because this is what we want to prevent. We want to prevent these early stroke recurrence that accounts for a large chunk of stroke burden and recurrence. And by this, of course, we use antiplatelets, and it's clear nowadays, but I will explain why it wasn't so clear a few decades ago. And in this slide, you can see a video, which is it's a nice live video from an animal model in which you born with laser the intima of that vessel, and you follow up live the formation of a thrombus. So what you see there in green and blue at the right extreme is the platelet formation, and what you see in red is the formation of the red clot. So it's a very good representation and gives you an idea about how a thrombus would be formed in real life. So antiplatelets have different mechanisms of action. The most frequently used, which is aspirin, is a cyclooxygenase inhibitor. It also shares the mechanism of action with triflusil. Thienopyridine derivatives such as clopidogrel or prasugrel belong to a different family. Prasugrel, widely used nowadays in cardiology, and phosphodiesterase inhibitors are used in the Western world, dipyridamole mostly, but in the Eastern world, cilostazol is widely used. The newest family of medications is the P2Y12 inhibitors, such as ticagrelor, which circumvents or bypasses the need for intermediary metabolism, such as clopidogrel. And the ones at the bottom are the intravenous antiplatelets, which won't be the focus of our talk today, and they are mostly used in cardiology, and although they have been used in acute trials in reperfusion and lysis in neurology and stroke, they are not widely validated and not recommended in general. So in terms of the use of single antiplatelet agents, I must say that until a decade ago, we wouldn't have even bothered giving a title to these, because that's all we had. We had single antiplatelet agents. A bit further down the line, I'm going to talk about dual antiplatelets as well. And but the first one we used were antiplatelets as a single molecule, and still they are the most widely used. There are several of them, but I'm going to focus on efficacy outcomes. They recruited more than 21,000 patients from 413 Chinese hospitals in the last decade of the last century, which sounds very remote now if we come to it. And they demonstrated a significant reduction of in-hospital deaths within the first 4 weeks of the trial in those given aspirin. So they saw that there were 5.4 fewer deaths for every 1,000 patients treated within those first 4 weeks with aspirin. They noted a non-significant reduction in recurrent strokes during those first weeks as well, which amounted to a reduction of 4.7 recurrent ischemic strokes per 1,000 patients treated. And there was a non-significant excess of 2.1 hemorrhagic strokes per 1,000 treated, and there was a significant reduction in the combined endpoint of death or non-fatal stroke in the aspirin group as well, with a relative risk reduction of 12%. On only a few, the ones that apply to our daily practice. So the first of these big, enormous trials that put aspirin clearly in the solid evidence arena was the CAST trial, which was Chinese. It was a randomized placebo-controlled trial using aspirin 160 milligrams versus no antithrombotic, started within 48 hours and given for up to 4 weeks. And they checked whether these patients would die from any cause within those first week or would be dependent or not at discharge. They had other secondary outcomes such as fatal or non-fatal recurrent stroke, but we are mostly interested in the primary done at the same time of the Chinese. With the Chinese trial was the international stroke trial, which involved mostly Western population. So this international stroke trial assessed the separate or combined effects of aspirin and heparin. And it was different in design from the Chinese acute stroke trial, in that at that time in the 90s and 80s, there was still these different currents of treatment regarding acute stroke. Anticoagulation was used a lot, and there was no solid evidence saying, well, should antiplatelets be enough, or should we anticoagulate patients? Will that help in reducing further strokes? What's the harm derived from it? And all those questions were or tried to be addressed by the IST rather successfully, but we'll see at what cost as well. So it comprised 36 countries, and they used aspirin 300 milligrams with or without different doses of unfractionated heparin, 5,000 or 12,500 units BD within the first 48 hours after stroke onset, and for 14 days, which is, as we have identified now, the period or one of the periods of highest risk. And the primary outcomes were of death from any cause within 2 weeks or dependence at 6 months. The secondary outcomes were mostly related with safety regarding symptomatic intracranial hemorrhages or recurrent acute ischemic strokes within 2 weeks, or other type of hemorrhages or other severe vascular events such as pulmonary embolism. The trial design, if you see it, is quite daunting. I mean, it's I really wonder whether any trial would get away with this design nowadays, because you have almost 20,000 patients who were randomized into 6 different groups. So you can see here, one group had aspirin combined with 12,500 units BD of heparin. Another one had aspirin with a lower dose of heparin. Another had aspirin without heparin, and another had only heparin at high or middle doses, and another and there was a group which had none of them. So it was a complex design, and but I mean, they got away with it, and it actually was quite successful and gave us loads of very valuable information, as we'll see. So the IST, in terms of those who were given heparin in different combinations, showed that there weren't significantly fewer deaths in those who received heparin. There were only 3 fewer deaths per 1,000 patients treated. And they did note, and they did find that there was a significantly fewer recurrence of acute ischemic strokes within those first weeks. They had the absolute numbers were 2.9% in those who received heparin versus 3.8%. That's a significant number. However, that was largely offset by the increase in hemorrhagic strokes that they had, which was actually 3 times those from that didn't receive heparin. There was a highly significant excess of 9 transfused or fatal extracranial bleeds per 1,000 patients treated, and actually at 6 months there were no significantly more deaths in patients treated with heparin, but they did have this very marked excess of bleeds. In contrast to those who received heparin, those treated with aspirin again didn't have a significant reduction in deaths at 2 weeks. There were 4 fewer deaths per 1,000 patients treated. They did notice a reduced recurrence of acute ischemic strokes by 2 weeks of 2.8% versus 3.9%, and in contrast also to heparin, this benefit was not offset by a significant excess of hemorrhagic strokes. So that was good news. They did notice a significant reduction in death or any non-fatal recurrent stroke of 11 fewer cases per 1,000 patients treated, and there were also fewer deaths at 6 months, which remained significant after adjusting for the predicted prognosis. There were 14 fewer deaths. So in what these trials showed us is that antiplatelets such as aspirin, given the doses for this trial of 300 milligrams, reduced the risk of recurrent strokes, reduced the risk of death, and it wasn't at the expense of increasing the risk of hemorrhages. The IST was published practically at the same time with the results of the CAST, and it could compare a bit its information with them, and the conclusion was that these trials suggested a small but worthwhile improvement at 6 months, and taken together with the results from the CAST trial, aspirin produced a small but real reduction of about 10 deaths or recurrent strokes per 1,000 patients treated during the first few weeks. And this is the reason why we use aspirin early in the first 2 weeks nowadays, and we prefer it to anticoagulation, because this trial showed us very clearly that there was no added benefit and instead just increased risk. But of course now we come with dual antiplatelets, which are the new kids on the block and are all the fat, and you might have heard talk about them all quite a lot, and during our ward rounds in our stroke unit you might have had to endure my recitation of the indications over and over again. I apologize, but I really hope the message has gotten through. And so one didn't seem to be enough, so now we come with a whack of the combination. So the first of these trials was the CHANCE trial, published in 2013. was a Chinese trial done at 114 centers of patients with a minor acute ischemic stroke, and this is very important, and I want to re-emphasize, with minor acute ischemic strokes with an NIHSS of 3 or less, or patients who have high-risk TIA with an ABCD2 score of 4 or more. I must be honest, the only reason why we use ABCD2 nowadays in clinical practice in a stroke is just to obtain the score, to decide whether when a patient has had a TIA merits being given a dual antiplatelets or not. We don't use it for any other reason nowadays. And this treatment had to be started within the first 24 hours after symptom onset, and of course patients who had a suspected or confirmed cardioembolism were excluded from this trial. So patients were allocated to two groups. In one group, you gave a combination of aspirin and clopidogrel, and the clopidogrel was started at a loading dose of 300 milligrams, followed by 75 milligrams daily for 90 days, and aspirin was given 75 milligrams daily from days 2 to 21, and that was after a loading dose that was at the discretion of the treating physician, and that could oscillate between 75 and 300 milligrams. And that aspirin was given only for 21 days. Therefore, you would have two arms, one receiving aspirin clopidogrel for 3 weeks, followed by clopidogrel only until the third month, and another one who received clopidogrel only. The primary efficacy outcome was of any new stroke, either hemorrhagic or ischemic, at 3 months, and the primary safety outcomes included moderate to severe bleedings as per the Gusto classification. The baseline populations were comparable. Median age was 62, 63 years. Most patients were randomized at the hour 13 after stroke or TIA or symptom onset, and we can see here that 2/3 of patients roughly were minor strokes, and the remainder were TIAs. This was a positive trial. It showed a hazard ratio of 0.68 for a stroke in patients who received the dual antiplatelet treatment. That's about a 32% risk reduction of a stroke during the trial period, and this held true still for the composite secondary outcome. This didn't happen at the expense of increasing the risk of severe bleedings, which was good news. Additionally, well, we can see here this is a Kaplan-Meier curve, but the important thing to note is that the curves divide very early in the treatment, accounting for most of the differences. At this point, which would be about 2 weeks, but usually in the first month, that's when the curves open, and after that month, they remain fairly parallel. I mean, there are no major changes after that period. So the sweet spot seems to be this first month, and that was seen clearly by this trial. But us being a skeptic, of course, the Chinese acute stroke trial was the chance trial was important, but nevertheless, the Western world was still quite skeptic. It was done in a Chinese population, and we know that the responses of the Eastern population can vary with respect to those in the Western world, and there are some examples for that I won't mention. So there was a need to try and replicate those results in a Western population, and that was what the POINT trial was for. It was published in 2018, but it pretty brought to the Western world the use of dual antiplatelets. This was a randomized, double-blind, placebo-controlled trial of comparing of patients with minor acute ischemic stroke with an NIHSS of 3 or less, or high-risk TIA, ABCD2 4 or more, given within 12 hours of onset, and the treatment allocation was more aggressive. I mean, in the POINT trial, patients received a loading dose of 600 milligrams of clopidogrel, followed by 75 milligrams from day 2 to 90. That means they prolonged the dual antiplatelet treatment for 3 months. And they gave ASA for, I'd say, varying dose. Again, it was to the discretion of the treating physician, between 50 and 325 milligrams. And they recommended 162 for 5 days, followed by 81 milligrams, but people could use what they preferred. And they kept these dual antiplatelets for 3 months. And the other group was placebo with aspirin. And the primary efficacy outcome was a composite risk of ischemic stroke, MI, or death from ischemic vascular causes, and the secondary efficacy outcomes were of each of them separately. The primary safety outcome had to do with risk of major bleed, which I won't go into specifying exactly. And this trial had to be stopped. Its recruitment had to be stopped in August 2017 because they reached the safety signal for major hemorrhage. They managed to recruit by then 84% of the anticipated number of patients, which were 4,881, and most of them completed the follow-up. It was a positive study. They noticed that the primary efficacy outcome was 5% in patients on the combination of aspirin clopidogrel versus 6.5% of those on aspirin alone, and there was that accounted for a hazard ratio of 0.75, which would be roughly about a relative risk reduction of 25%, which was statistically significant. This is the formal table of results, and you can see here that the secondary efficacy outcome of individual each individual group of outcome separately showed that actually stroke patients, ischemic stroke, were the ones that benefited the most, with a relative risk reduction of 28%. However, in this trial, this came at the expense of increasing by more than 2 times the risk of a major hemorrhage. And of those, many of them were also major systemic hemorrhages or minor hemorrhages. So there didn't seem to be a marked increase in symptomatic intracerebral hemorrhage, but it was rather systemic. What they concluded was that for every 1,000 patients who are treated with clopidogrel and aspirin for 90 days, the treatment would prevent approximately 15 ischemic events and would cause 5 major hemorrhages. But again, and that's the reason for me to put here these Kaplan-Meier curves, the major benefit happened early. It was, you see these curves opening very, very early. And you see at 1 week, and then at within the first month, you see that the benefit is most evident, and afterwards the curves run pretty much parallel. Then the other attempt of demonstrating the benefits of dual antiplatelet therapy with different medications was the Thalys trial. The Thalys trial combined ticagrelor with aspirin. This was published less than 2 years ago in 2020. And this was a multi-center randomized double-blind placebo-controlled trial, parallel group, all the bells and whistles in trial design, in patients who had a mild to moderate, and that's the difference, acute non-cardioembolic ischemic stroke that was with an NIHSS not of 3 or less, but of 5 or less. So they moved the goalpost a bit ahead. It's still quite meek, quite timid, but nevertheless try to encompass a larger population of stroke patients, and TIA patients had an even higher risk of an IVCD2 score of 6 or more, and also patients who had asymptomatic intra-extracranial significant stenosis. The patients had to be randomized within the first 24 hours after last seen well or witnessed onset, and they were randomized to either aspirin ticagrelor or aspirin placebo. Ticagrelor was given as a loading dose of 2 90 milligram tablets or placebo, and maintenance dose was 90 milligrams BD or placebo for 30 days, and aspirin was given as a loading dose of 300 to 325 milligrams, and maintenance was in between 75 to 100 milligrams for 1 month. So this study used the dual antiplatelet therapy for 30 days. The primary outcome was a composite of stroke or death, and the strokes included both ischemic and hemorrhagic, which can be a bit tricky because hemorrhagic would be more sometimes a safety outcome than an efficacy outcome, but some groups prefer to do it that way. And secondary outcomes were the first recurrent ischemic stroke. The primary safety outcome, of course, had to do with a lot with bleedings. The populations were fairly comparable. No major surprises there. And for the primary outcome, they had a positive result. They showed a hazard ratio of 0.83 for the primary outcome of a stroke or death. That means about 17% relative risk reduction of a stroke or death in those treated with the combination, and that held particularly true for those patients with ischemic stroke, where the relative risk reduction was about 21%. However, this came at the expense of almost increasing by 4 times the risk of a severe bleeding, or which accounted, in contrast to the other trials, the Janssen point, to a very prominent increase in intracranial hemorrhage or fatal bleeding, which is not very encouraging. And now, thanks to our beloved Cochrane database of systematic reviews, so we can summarize the results of oral antiplatelets for acute ischemic stroke. They talked mostly about single agents, therefore they comprise mostly aspirin, which is the largest in the number of trials, and only a small one with clopidogrel that I will mention. So this Cochrane systematic review had, as you could expect, very stringent criteria to be included. These had to be trials with a very low risk of bias, and as you could expect, most of the information, at least in this comparison, came from the 2 largest trials, CAST and IST, that we talked about. And for the outcome of a complete recovery from stroke, they noticed that there was a significant benefit from the early use of aspirin, and a odds ratio of 1.06 for regaining, for having a complete recovery after the stroke. In terms of the risk of recurrent stroke, it also showed, this review, that there was a significant impact of the early use of antiplatelets in reducing these recurrent strokes. The odds ratio was 0.79, which roughly means that about 21%, there was a relative risk reduction of about 21% of these recurrent strokes. It's worthwhile mentioning, just to spice up the conversation a bit, that the only trial that held its grounds sufficiently for the Cochrane team was this using clopidogrel by Shao, which didn't demonstrate a significant benefit of the early use of clopidogrel, but it was a small trial, so but apparently was the only one with adequate design. So this table is a beautiful summary of all the data analyzed by Cochrane, and it showed that for every 1,000 people treated with aspirin who had an acute stroke, there would be 13 deaths or patients left with dependence avoided by every 1,000 patients treated. So that's good. There were 13 patients less with that outcome for a number needed to benefit of 79. That is, you need to treat 79 patients to avoid one outcome of death or dependence. And the deaths from all causes were also reduced, so 9 could be avoided for patients treated with aspirin. Only 1 event of pulmonary embolism would be avoided for patients treated with aspirin early. And in terms of recurrent ischemic stroke, 7 recurrent strokes would be avoided per 1,000 patients treated with aspirin, with a number needed to benefit of 140. And this would happen at the cost of an excess of 2 more symptomatic intracranial hemorrhages during treatment, and 5 more recurrent strokes or intracranial hemorrhages during treatment, and 4 more extracranial hemorrhages. But you would also have the benefit of 11 more patients recovering completely from the stroke by the sole fact of having been given aspirin early. So these were quite very clear-cut results from the Cochrane review. So now, based on all these trials we have mentioned, it all boils down to what is included in guidelines. So what do those guidelines show around the world? The first ones, and perhaps the most important in America, and by America I mean North America, Central America, South America, are the guidelines from the American Heart Association, American Stroke Association, which recommend the use of aspirin in patients with acute ischemic stroke within the first 24 to 48 hours, with the proviso that what we know, that patients who have received IV TPA alteplase shouldn't receive aspirin in the first 24 hours after the dose of TPA. And they clearly state here, and this is pretty much of a very significant change, that patients presenting with minor non-cardioembolic ischemic stroke with an NIHSS of 3 or less, who did not receive alteplase, should be started within 24 hours on the combination of aspirin clopidogrel, and this should be continued for 21 days, and because this is effective in reducing the risk of recurrent stroke. They certainly do not recommend the use of ticagrelor in monotherapy, and although not shown here, there was a trial published in 2016 which demonstrated that ticagrelor in monotherapy was not superior to aspirin in monotherapy. The European Stroke Organization published its guidelines in last year, and they also clearly state that dual antiplatelet therapy with aspirin clopidogrel for 3 weeks should be offered to patients with minor stroke, NIHSS score 3 or less, or patients with high-risk TIA with ABCD2 score of 4 or more, with a high quality of evidence and a strong being a strong recommendation for intervention. So I think with all this, it seems pretty clear nowadays that patients who fulfill these criteria should be offered dual antiplatelets, but it should also be restricted to that population, which is a relatively minor population. I was surprised to read this recommendation too regarding dual antiplatelet treatment with aspirin and ticagrelor, which derives directly from the Thalys trial. And they said that patients with NIHSS 5 or less or high-risk TIA with ABCD2 score of 6 or more, they suggested 30 days of dual antiplatelet therapy with aspirin and ticagrelor. So in clinical practice, I find that a bit painful to apply because of that tremendous increase in bleeds, not only systemically but intracranially, and perhaps the little a nuke in which patients that would fit in there would be those patients with an NIHSS of 4 or 5, or those with a TIA of a much higher risk, above 6. So that range, that little population of patients would be the ones that perhaps could use this treatment. But I find it really hard to argue in favor of it, given the very prominent risk of bleed. Our NICE guidelines advise what we do in everyday practice. Patients should be offered aspirin 300 milligrams within the first 24 hours, and it should be given by either way, either orally, or if they are nil by mouth, rectally or by enteral tube. And that aspirin should be continued for 2 weeks. And that's why we do what we do every day in the stroke wards. And that, of course, you all members of our team know that painfully. The use of clopidogrel and modified release dipyridamole within the NICE guidelines was clarified in this document, the T8-10, and they apply to patients who have had any occlusive vascular event or who have established peripheral arterial disease. They don't mention about early treatment, and I really want to emphasize that. It's a general recommendation for patients with any vascular events that could benefit from using clopidogrel. The same applied for modified release dipyridamole. They are not specifying whether this is for early or late treatment. It's rather vague in that sense. It's a general umbrella recommendation. Of course, because of all the many analyses they did, they advise that because of its cost, if you are going to start clopidogrel, it should be given in the cheapest presentation to the system. What do the National Clinical Guideline for Stroke, the NICE and Royal College of Physicians advise? Well, for TIAs, they said, please give aspirin 300 milligrams as soon as possible. And those patients should be assessed within 24 hours by a specialist physician or stroke team. Once the TIA has been confirmed, then those patients should receive clopidogrel 300 milligrams loading dose, followed by 75 milligrams daily thereafter, and high-intensity statin therapy. And this is where I find that the evidence might not be as supportive. And I am a bit critical and a bit rogue in this sense. If we are to be true to the evidence, there is no, to my knowledge, and after reviewing it everywhere, There is no evidence about the early use of clopidogrel in the acute early stroke scenario. The trials that have used clopidogrel early are within dual antiplatelet within the dual antiplatelet context, and perhaps the one that used the clopidogrel like we use it is the Chinese acute stroke trial. So suggesting that all patients with a TIA have the aspirin, sure, agree with that. Early, as soon as you know it's a TIA, please, as soon as you suspect it, start aspirin, 300 milligrams. When they are seen by the stroke clinic, then switch to monotherapy with clopidogrel. If that is to happen within the first 24 hours after referral, or which would be usually within the first 2 weeks, I really find it hard to justify. If you remember that that information from the Cochrane collaboration, that systematic review, the only trial using monotherapy with clopidogrel early that passed their tests was the small trial from 2017, and that trial didn't demonstrate that early clopidogrel use was favored. So that's why I have this gray area. Of course, I'm not the Royal College of Physicians, and of course, there was a large number of people involved in analyzing these, but yeah, I think the evidence may not be as supportive for that particular indication of TIA and using clopidogrel during those first 2 weeks in high dose. But there are pros and cons, and their conclusions are valid and are valid for our particular population. So that's why we stick to them. The recommendations for acute ischemic stroke are pretty much in line with NICE. They say, well, give aspirin 300 milligrams daily and until the first 2 weeks, and then switch to clopidogrel or whatever anti-platelet treatment you want to provide. If you're allergic to aspirin, then give clopidogrel. So in summary, after this very fast-paced tour de force among the evidence of the use of antiplatelets in early ischemic stroke treatment, what we know is that aspirin 300 milligrams should be given as soon as possible after patients have had a non-cardioembolic acute ischemic stroke, and it should be used for the first 2 weeks because it does reduce the early recurrence of a stroke, and because it has a modest albeit significant effect in reducing mortality and in increasing independence after stroke. I always emphasize, and it can seem a bit pyrrhic, a bit small change to us, these numbers, but these trials arose at a time when we didn't have thrombolysis widely available, and even nowadays most patients do not benefit from thrombolysis because they don't receive it. They simply arrive late in the time window or have contraindications, and in the best of cases, in UK about 12% of patients with an acute ischemic stroke benefit from thrombolysis. The remainder don't have it. So that's why it's so important that we know very well how to prevent the recurrence of strokes early, and that's the reason for this for this presentation. And it's clear nowadays that in patients with minor acute ischemic strokes, that is, again, I parrot the same thing because that's what the trials tell us, with an NIHSS 3 or less or high risk TIA with an ABCD2 of 4 or more, patients who have that should have that combination of aspirin clopidogrel. It should be given for 3 weeks, that is 21 days, not more than that. And that has proven that it's superior to monotherapy with either of clopidogrel or aspirin in preventing recurrent strokes without significantly increasing the risk of bleeding. Within the UK, and that is a very particular a proviso in patients within the UK and who have had a TIA, ASA 300 milligrams is given in a loading dose, and as soon as the TIA is confirmed, they are to be switched to 300 milligrams of clopidogrel as a loading dose, followed by 75 milligrams thereafter. Still, the big void in evidence and trials in terms of further reducing the risk of stroke recurrence is in the patients who have a moderate to severe acute ischemic stroke, in whom the risk of hemorrhagic transformation from using more aggressive approaches of dual antiplatelets might not be sufficient. I really wonder whether someone will have the guts to carry out those trials. I think it would be hard to argue in their favor, given the known risks of hemorrhagic transformation. So that will be all from my part. The advantage of, well, perhaps from my side, the advantage of having been able to record this presentation was that I didn't have the time constraints from the live event, so I could extend a bit more into some issues. I hope the presentation has been useful. I hope you'll be able to apply it to your daily practice, and we'll see you next year.